Ladies and gentlemen, I would like to welcome you on our first ESWV Vision Dry Eye Symposia. And I got this privilege to welcome you here. And it's a big honor for me that after hard work, almost 2 years, we are ready to show you the data from our international data collection that's been collected from a lot of countries. And me, personally, been involved in this project very closely, working with beautiful people, and enjoy all these 2 years. And now, when it's time to show something, I'm really excited. My name is Peter Baranovic, and I'm a commercial director of ESWV, responsible for vision side. So I will be happy that you would enjoy these couple moments that our doctors, our friends will present incredible work they did it in 2 years. I will be happy also with you to enjoy this joy that we have in our devices, in our products, and the joy that we give to our patients finally. And we are so proud that we really makes the patient eyes happy again. So please let me to introduce you Liliana Nobrega, our moderator for this evening. And Liliana is the Brazilian doctor. She's currently director of ophthalmo laser clinic in Victoria, a beautiful town in Victoria in Brazil. And she's a passionate doctor. And I love her for her personality, her passion that she's giving to her patients. And today she's our lovely moderator for this beautiful symposia. She's the vice president of Ophthalmology Society in her state, and she gives a lot of lectures, and I'm happy that she is our friend and our supporter of our excellent technology. So Liliana, please, if you can help me to start up this show that everybody would enjoy. Thank you so much that you come.
Thank you. So welcome everybody to the first symposium in dry eye disease. I'm very happy to be here with all of you this afternoon and this beginning of the evening. And I'm going to be the moderator of this discussion, so it's a pleasure for me. And I want to introduce Andres Benatti, who is going to give a lecture about dry eye, and he's going to talk about the importance of dry eye screening and treatment. Andres is from Argentina, and he runs Ophthalmo University from there, and he gives a pretty much importance to dry eye management as anterior segment surgeon, and you play a really nice work in educating ophthalmologists in Latin America and all around the world. So welcome, Dr. Benatti.
Well, thank you, Liliana. Thank you, Peter, Petra. Thank you, all of you guys, for being here. And we're going to start with this talk about the importance of dry eye screening and treatment. Let me see here. Perfect. This is a little different talk that we usually are used to, because I would like to talk to you guys about the numbers around dry eye and the importance of having this in mind for our practice, our clinic, and our profession. So today we're going to talk about different topics: global market dry eye disease, the problem about, there's a problem with the presentation, just that. No worries, that was just the topics of the talk. Let's start with this, the global market around dry eye disease. In 2021, we had 5.22 billion of dollars that was all the market around dry eye, but it's projected for 2027 goes to the $6.54 billion, increasing almost 5% per year. If we see the ophthalmic medications produce $36 billion per year, and dry eye drops or dry eye medication represent 12% of those $36 billion. So it's a huge market. We're talking about a lot of money, and increasing here is 7% until 2021, until 2032, sorry. But between 2016 and 2021, the increase was just 6%. So what I want to say with this, the market is going up, and we have to be aware about that. What is the problem that we have today with dry eye and all these pathologies around, like CVS and all this problem? Well, we are seeing that there are much more visual displays workers. After pandemic, this was a boom, right? The home office is increasing because we understood that we can do that work from house. Maybe sometimes we don't have to go to the office. And again, after pandemic, we realized about this. Smartphones, well, we are all the time with smartphones, but the problem is the kids. Kids are spending a lot of time, more than recommendable, on the phones. I'm talking about 5, 6, 8, 10, 12 years old. Gamers, and let me tell you why I'm talking about gamers. That's at least for me, and for sure maybe of you guys, it's something that we are not used to. Gamers, what is that? Well, these are young people who spend time and make money gaming video games, right? And they spend 12 or 15 hours on the screen, on the computer, playing video games. And life expectation, of course, that is increasing every year. But at the same time, on the other hand, we have a reduction in the productivity and the quality of life. So, kids, this is a paper presented in this year, 2023. The researchers, they put a class with a camera in the kids, and they gave them a cell phone. And they explained that they have to play with the phone for just 1 hour. After that, they studied and they realized that they started with dry eye symptoms, and the blinking rate was in a reduction of almost 50%. They blink usually 20 times per minute, and when they are on the phone, 8 or 9. So, and this is just when 1 hour. Imagine when your kids are 5 hours or 4 hours with tablets and phones. Gamers. So in a few years, this will be a 3 billion people market, because by 2024, there are expected to be 3.32 billion gamers worldwide. I'm talking about almost half of population of this world will be gamers or YouTuber or whatever you want. The result of this is a lot of people spending too much time on the computer or on the screen. Between 20 and 60, like all of us almost, CVS, we spend a lot of time working, doing paper, presentations. We are doctors, but we spend a lot of time on screen. And CVS, as you can see in that part of the screen, it's worldwide. It's a pandemic, a new pandemic, because it doesn't matter if you are in Pakistan, Egypt, Ethiopia, Italy, or Brazil, there is a huge prevalence of CVS in the world. And CVS, this is a paper that showed that there is 60 million people suffer CVS. For me, it's much more than that. But every year, we have 1 million people, new people, suffering this syndrome. And let me tell you something. The first symptom of CVS is headache, but the second one is dry eye. Well, after more than 60 years old, it's a geriatric population. They are, if you can see, in 2050, the geriatric population goes from 750 million to 1 billion. We are going to duplicate by 2050 this kind of population, and they have problems like all the problems that we have when we are more than 60 or 70 years old, and dry eye is one of them. So, we're talking about maybe for the very first time a pathology who is affected 4 generations. As you can see here, I don't know if there is another ophthalmic disease that affect all these kind of people. All generations are affected by dry eye. So that's mean that the patient that we're going to have in the future is huge, and we have to be prepared to face this problem that we already have, and it's going to be worse in the future. So what is the problem again? The reduction in the productivity and a loss of quality of life. Let's talk about a little bit about productivity. There is an average of that the workers that they have dry eye, they spend almost 200 days suffering symptoms of dry eye. That means that they are not working 100%. They are suffering the symptoms, and their productivity goes down. If you have a mild dry eye, you can have an 11% of loss of productivity. In the moderate dry eye, it's almost 20%. But if you are a patient with severe dry eye, you can have a 35% of loss of your productivity. And that is a lot of loss of productivity for the companies and for the workers. Let me show you an example. Japan, it's a country which lost almost $15 billion in productivity. Why is that? Because they have 55 million workers in Japan, office workers. The incidence of dry eye, it's among 23 and 32%. The cost per every worker is $741, and if you do the count, the number is that. But the interesting thing about that, for us, the ophthalmologists, if we treat those patients, just 10% of those patients, we're going to save the health system in Japan. We'll save $1.5 billion. But if we can treat 50% of all those patients, we can save almost $8 billion. So let's imagine for a minute how important is this for the countries and for the health systems. Canada, it's another example where they are losing a lot of money in productivity. Let's go to the severe dry eye. They can spend more than $25,000 between direct cost and indirect cost. Direct cost is the medications, the treatment, but indirect cost is the time that you lose to go to the doctor when you are with a reduction of your productivity. If you combine that, you can see that the table, there is a lot of money that or the country, Canada in this case, is losing. What about quality of life? And this is, for me, one of the most important part of the talk, because we are talking directly about our patient, that we know that is the most important thing. If you see this table, you can see that they compromise general vision in different pathologies, right? Like, I'm sure you can see from there, but there is retinal detachment, glaucoma, I don't even can see the last one, but I think it's maculopathy. So dry eye is always the first one, right? So if you see the males and the females between 20 and 40, dry eye is the first pathology who compromise the general vision. The same in females and males between 40 and 60, and forget it when you see the square in the more than 60 years in the case of females. You can see the numbers. It's double most important dry eye that, for example, glaucoma. But if you see this one, when they take these parameters, like for example, driving, ocular pain, of worry, patients, the big one bar, the brown, it's severe dry eye, right? Or patients with highly symptoms dry eye. They are more worried for this pathology than, for example, for glaucoma. Driving, they feel worse, the patient that they have high symptoms dry eye, when they are driving than, for example, a patient who has macular degeneration. So what I want to say here is that dry eye, when it's highly or severe dry eye, is a huge problem for our patients, right? At the same level that maculopathy, glaucoma, or retinal detachment. Let's take a look the bar that goes down. This, again, is severe dry eye, and you can see how affect in different parameters our patients. For example, role physical, bodily pain, general health, mental health. So all these parameters are very affected in this kind of patients. So what do our patients need for treat this or try to give a solution of these patients? Well, we definitely need a comprehensive management. That's why in Argentina we are redesigning the concept of ocular spa. We launched Dry Spa, who has 4 pillars: diagnosis, treatment, multicentric data, there's a mistake, and education. These 4 pillars are for us the most important thing of this project. As you can see, they are very connected. All are connected and linked, and I'm going to tell you why. Well, our mission is to improve the quality of life of our patients by providing service of excellent and high standard in quality and medical evidence and state-of-the-art technology. Let's start with diagnosis. For me, maybe it's the central core of this project. Why? Because the first step that we have to give is a good diagnosis, a smart and efficient diagnosis. It's not the same to tell to your patient that they have dry eye, look in the slit lamp, that if you have this tear check, and you can show the patients all the parameters affected. And this is really connected with education, because we are doing education to our patients. They now understand what is happening with their eyes. And there is not the same when you say your breakup time is affected. Look in the slit lamp, that patient doesn't understand anything. When you see, look, this is your diagnosis, the breakup time is broken because this and this, now we have to start a treatment. Sorry. So why it's important a smart and efficient diagnosis? Because we can, again, educate the patient for a better understanding of the disease and for adherence of the treatment. This is so important. We can personalize the treatment because we can understand if we are in front of what kind of dry eye we have, an aqueous deficient, or maybe with evaporative dry eye. And also, that other point is very important, data recollection, because we can better understand the results and we can treat in a better way our patients. So treatment, you know, we have very different treatment. We have topical, oral treatment, mechanical, habits is very important. But these two, for me and for our project, is also very important. Education and lifestyle. We can give the best treatment possible today, but if the patient don't understand that lifestyle is very important, the results are not gonna be good. The other part, it's ophthalmologist education, because as Lilian said, we need to train our colleagues. We have to understand, and when we do the residence or when we go to the hospitals, nobody teach us dry eye. We can say this is like a new specialization, because in resident it's very short, at least our generation, the part of dry eye, right? So we have a new problem here, and we need also educate our patients. We have a platform, dryeyementors.com, where we are offering courses, webinars like the webinar that we do together for all Latin America, boot camps, and this is just for our colleagues. And we also have developed Dry Spa exclusive program, because as I just said, it's very important for me, the educations. We have a regenerative vision program. The E-Eye program is a educational lifestyle and a strategic prevention program. In all our dry centers, our doctor has to understand this, and we can offer these programs to improve the results and to improve the experience of our patients. And finally, multicentric data. We are working with Revi. It's a startup from Argentina, from Dr. Saldivar, who allowed us to collect all data about results, about treatments, and analyze in a better way. So we must add value to our centers. We need to surround our treatment about all these things because I truly believe that the patient experience is one of the most important things as the results, the good results. And in conclusion, dry eye disease is and will continue to be a growing health problem for our specialty and the health systems. We must be prepared for the next years, and preventions and maintenance is one of the most important things, I would say, the priority for us. And the conclusion for us, the ophthalmologists, well, it's not enough to offer medical solution for dry eye. We need to give a comprehensive solution for all of our patients. We must provide the patient journey, a good patient journey, a good patient experience, and this will allow us, of course, to differentiate ourselves in a growing but highly competitive market. That's it. Thank you so much for your invitation again and for your time. Thank you, Linda.
Thank you, Dr. Bernati. Excellent lecture. Gives the real importance of the management of dry eye disease. And we are in the front of this battle to educate not just our patients, but ophthalmologists in our countries and all around the world. So I will begin my presentation. Just 1 minute. That's it. So welcome again to this Dry Eye Management Symposia. This is the presentation of post-market clinical follow-up study of dry eye analysis for the validation of the interpretation grading scale for examination of dry eye disease. The study purpose was to evaluate the effectiveness of using the interpretation grading scale for examination of dry eye syndrome in outcomes of post-marketing clinical follow-up study of dry eye analysis and using the IRPL, intense regulated pulsed light, applied to the periocular area of the patients with MGD or dry eye disease in improving both subjective and objective measurements from the tearcheck. We have 7 centers participating in this study with 1,700 patients from 6 countries worldwide and 3 different continents and all types of population. So I am the main investigator of this study together with Dr. Siganos from Greece, Dr. Gontijo, also from Brazil, Dr. Lau from Malaysia, Dr. Strate from Romania, and Dr. Maritic from Slovakia, and Nurse Stiskalova, also from Slovakia. And Dr. Benati from Argentina. This is the data collection time frame. In 2021, we did the enrollment of the patients. 2021 and 22, we did all the dry eye disease measurements in the tearcheck device, and treatments were performed with the E-Eye IRPL, treating the patients with 4 sessions. And 2023, the analysis and the presentation total 1,706 patients were assessed, and 818 patients complete full treatment. The inclusion patient criteria. We included patients with lacrimal dysfunction and meibomian gland dysfunction who were eligible for IRPL therapy. And we excluded patients with previous ocular surgery, pregnancy, breastfeeding, corneal degenerations, etc. So this is the tear check for a smart dry eye screening or a smart dry eye analysis. It makes 9 exams. It's very easy, very fast for a smart screening. These are the 9 exams that tearcheck performs. And tearcheck can perform subjective measurements, objective measurements. You can repeat over time. You can make documentation. You can make reports to your patients. It's dedicated for a smart screening, but can also be a guideline for diagnostic. So this is the first exam. I always start with the eye fitness test, which is a subjective test. It's a questionnaire that provides feedback about the severity of dry eye symptoms over the quality of vision and quality of life. This is the TFSA and NIBUT, tear film stability evaluation and non-invasive breakup time. Both exams evaluate the stability and the breakup time of the tear film. This is the eye redness. So this exam captures images of the bulbar and tarsal conjunctiva. This is the meibography, when we can finally visualize the meibomian glands, the percentage of loss, and the morphology. Abortive blinking. This exam shows all blinks identified within 60 seconds to determine complete and abortive blinks. Signs of Demodex. This is an enlarged image capturing the base of the eyelashes to evaluate signs of Demodex. This is the ocular surface inflammatory evaluation. We use fluorescein to perform these exams, and the fluorescein mark these suffering zones, indicating an inflammatory process in the ocular surface. And finally, tear meniscus high shows us the high of the tear meniscus. We also perform our classic exams in our offices, like shimmer tests and Lissamin green staining for comparison with the measurements of the tear check. Some challenging diagnosis for us is when we have symptomatic and asymptomatic patients. The tear check can identify those asymptomatic patients. They are not complaining about dry eye when they get to our offices. When you have these patients, it's very difficult to convince them to go for treatment because they are not suffering from the disease. They are not having the impact in the quality of vision or in the quality of life. On the other hand, symptomatic patients suffer a lot from the disease. So they are very conscious about the disease and they are looking for solutions. So this is the time for these patients go for treatment. Unless you are screening your patients in big centers, in big hospitals, and you find an asymptomatic patient, and you're going to perform an ocular surgery in these patients, so you can educate better and prevent complications after the surgery. So it's a very educational tool for asymptomatic patients, and you can give too much value to these findings and treat and prepare the ocular surface to the impact of an ocular surgery. This is the interpretation grading scale for examination of dry eye from the tearcheck. This is an example of a report. It helps us identify asymptomatic from symptomatic patients, because in dry eye disease, you have this dissociation between signs and symptoms. It's very common. So you can look, patient can look and suddenly understand their conditions. It's easy for the patients to understand their conditions when they look at different colors like this. They can see the green is normal, the yellow is mild, orange is moderate, and if they had the red, they had a severe condition of the ocular surface. When you show images like Dr. Benatti said, you have more compliance for treatment. It's very different when you just tell your patients you have evaporative dry eye because of meibomian gland dysfunction. The patient cannot visualize that. But when you show images, it's easier to convince your patients to go for treatment. Talking about treatment, let's talk about the intense regulated pulsed light from ESW Vision, the E-Eye. We treated those patients with 4 sessions, applying 5 pulses around the eyelid in each eye. The skin must be clean, without makeup or sunscreen. This is the E-Eye. In E-Eye, this technology, IRPL, has a polychromatic light source ranging from 515 nanometers to 1,200 nanometers, with different colors and different wavelengths. These different colors have different penetration in human skin. This is a unique IRPL technology. It has a different pattern and effect in absorption in the skin. And each flash has 8 specific sub-flashes. So this microgradient of temperature triggers the liberation of neurotransmitters, in this case acetylcholine, stimulating the postganglionic neuron, which is connected to the parasympathetic ganglia and with preganglionic neurons. We have the activation of the parasympathetic nervous system. We apply 5 flashes around the island, over the bulbar orbital and the zygomatic region. These are the regions where the parasympathetic nerve passes. So we have stimulation of these nerves that stimulate the meibomian glands and restore its activity. And we have improvement of the tear film stability. We have improvement of the non-invasive breakup time. We have improvement of the lipid layer, and we decrease ocular symptoms. So this technology has many mechanisms of action, such as the neurological stimulation. We can discuss it later with the panelists, but I think this is the key effect of this technology. So we activate the 2 branches of parasympathetic nerve, and we stimulate a normal activity of the meibomian glands. We have this warming and liquefying effect, helping the meibum to get out of the meibomian glands. We have this photomodulation effect. We stimulate mitochondria of mammalian glands, enhancing collagen synthesis. We have a vascular thrombosis effect. The heat decreases pro-inflammatory mediators in the ocular surface and decreases inflammation and telangiectasias. We have this antibacterial and anti-parasitic effect. So if you have Demodex, the pigmented exoskeleton absorbs the energy from IRPL and induces coagulation and necrosis. So we can kill Demodex. And we have this connective tissue rejuvenation, decreasing gland obstruction. So here's an example of meibography. So we always look at the meibomian glands to indicate the therapy, to choose patients who are eligible for the treatment. And we also respect the Fitzpatrick color scheme chart to manage the energy level. We don't apply the treatment in black people, but we can apply in dark brown or mild brown people by reducing the energy level. So for dry eye management, ESW Vision designed 2 steps. One, it's the analysis from the tear check, and step 2, treatment with the E-Eye. So this study went through some statistical analysis, and I'm going to present our results. So we have a total of 1,706 individuals that were measured with the tear check, and 818 people were treated with the E-Eye. We can see that 82% of our patients were women and 18% were men. So we are more affected by dry eye disease than men. And the highest number of patients came from Malaysia. The second highest number of patients came from Romania. And the third highest number of patients came from Brazil, from my center and Dr. Gontijo's center. And these are our results. This is very interesting. We are comparing Schirmer test with eye fitness tests. Schirmer test showed improvement and also did eye fitness test. And we can compare similar graphics with the Schirmer test, which is an objective measurement, with the eye fitness test, which is a measurement from tear check, and it is a subjective measurement because it is a questionnaire and it depends on the answers of the patients. We also found some similarities between Lissamina green staining with eye redness and ocular surface inflammatory evaluation. We can see similarities among the graphics, and Lissamina green is a subjective measurement that we perform in our offices because it depends on our evaluation of the patient. And eye redness, it's also a subjective measurement from the tear check because it also depends on the doctor's evaluation. But ocular surface inflammatory evaluation is an objective measurement from the tear check, and we could see the similarities among the graphics. This is a comparison between eye redness and ocular surface inflammatory evaluation. And we can see improvement in these measurements from pre and post treatment with IRPL. We also can see that the tear film stability evaluation and the non-invasive breakup time improved after the treatment with 4 sessions of IPL. This is a graphic that shows the blink rate. We didn't see any improvement after the treatment. And we also didn't see any improvement in the abortive blinking measurements. So maybe this is a sign that we must teach our patients how to blink. This is a mybography, lower mybography from the right and left eye. They both showed improvement in the meibomian glands. This is Demodex. We didn't find too much Demodex, but we could kill 100% of them with the treatment. And we also improved the tear meniscus height in 100% of patients. So coming to our conclusions, we could see from 2020 to 2022 an improvement in diagnosis of dry eye disease. We can see that this disease increases year by year. And like Dr. Bernati said, after the pandemic, things got worsened and patients are more symptomatic because we are in front of the screens all the time and we have our modern lifestyle affecting our eyes. Other conclusions of this study: more than 55% of total patients did not use any eye drops during the therapy. Satisfaction of the patients with subjective tests improved 80%. We have this high efficacy, easy and smart system for evaluation of dry eye disease by grading scale. The percentage of symptomatic patients from total up to 47%. So we can see how dry eye is the second most common eye disease in the world. Shows the global growth of this disease. And comparison between other tests showed similarity in the improvement of the patients. So we improved shimmer tests by 75%, and what we also improved eye fitness test by 73%. We improved tear film stability evaluation by 77%, and we improved no invasive breakup time by 75%. So we can see similarities between all those measurements. The ocular surface inflammation improved by 90% of patients, and the risk of inflammation decreased for 95% of patients. We have 100% improvement eradicating Demodex and increased lacrimal gland tear production. We increase patient satisfaction and treatment efficacy based on asymptomatic and symptomatic patient selection criteria. We improved practice workflow and efficiency for high-volume clinics with the tearcheck assessments to E-Eye IRPL treatments. And we have 0 adverse events reported in data collection. So this intense regulated pulsed light technology is recognized as a working solution for dry eye treatment. More than 2,500 sessions of treatment done with IPL, RPL from ESW Vision, and 0 accident reports. So the study proved that 96% of patients recommend the treatment, 80% confirm improvement of symptoms, and 55% stop using eye drops after the treatment. So these were our conclusions. This lecture was in English, but I want to say thank you in different languages in respect for all of you from different nationalities. So thank you very much for your attention. Merci beaucoup pour votre attention. Muchas gracias por sua atenção. Grazie per la vostra attenzione. Obrigada pela sua atenção. Dankeschön. And many thanks in other languages that I'm not able to speak yet. So thank you very much. We are going to have a round table now, so I invite you all to stay with us. We will have this discussion among dry eye specialists from 3 different continents. So let's do it now. I have some questions for you. Let's start with the ladies, with Dr. Strate from Romania. So, Dr. Strate, how looks your daily practice for treating dry eye disease?
I don't think it looks different from anybody's in this room, actually. So the patient checks in, you know, the usual complaint, something is wrong with my eyes, I have the gritty feeling, and something is abnormal, or I'm having an excess of tears. And this is the moment, actually, the technology comes in our clinic. So I refer the patient already for the tear check. And this was helpful, actually, the protocol, because I was the last one that began the protocol with. So for me, it was very important to follow up the steps. So it was the tear checkup. We are doing the Schirmer test and the Lismin green test. And then the patient comes into the office and we are having the discussion. And what goes absolutely wonderful is the fact that I can show them the pictures. And from that point, I feel that it's not any longer a discussion between the patient and the doctor. It's more like going to work together. You know, we are going to fight this. It's going to be long. I don't believe in miracles, but I'm here to help you, and let's personalize your treatment. So actually, it's more like a very nice dance around.
Very nice. I want to do the same question to Dr. Lau, because Dr. Lau, we saw in the study that the majority of patients came from your center. So I'm wondering if you use the tear check as a screening test in all your patients. How do you work? Tell us, please.
When patients come to our office, the first thing is that those who are symptomatic for dry eyes, they fall in a group that needs treatment. And those who are going for cataract surgery, whether symptomatic or not, we straightway do a tear check on them. Those who are going for LASIK treatment, we do this Schirmer's test for everyone who wants to undergo LASIK treatment. But those who fail the Schirmer's test are subject to tear check. And from there, we classify the NIBUD as mild, moderate, or severe. And those with moderate to severe, in a moderate to severe zone, we explain to them about IRPL. And because the patients can see the result, they can accept the fact that they need treatment that is more than just eye drop treatment. We always emphasize that you are now in a state where your severity of your dry eyes is either in a moderate or severe zone, and eye drops alone is not going to help you. You need more than that. And that's when we introduce the IRPL, and most of them will accept it because they can see the results.
And Dr. Tsiganos, how looks your daily practice for treating dry eye disease?
Okay, Liliana, I think I will get this from a different angle. My practice is at the university and my private clinic, and it involves in the cornea, which is my specialty, cornea external eye disease and transplantation, refractive surgery, cataract surgery. Okay, and these are all areas where dry eye is involved. So not all patients come with dry eye symptoms. So we have all these kind of patients, contact lens wearers, pre-operative for refractive surgery, post-operative, or for cataract surgery, as the dear colleague said. So one point of Dr. Benatti, which was an excellent lecture earlier, education also for optometrists, not just ophthalmologists, because we are combating this together. The optometrist is very important because you see much more problems than dry eye from contact lenses, both through the internet. Okay, and now we have, I think, flourishing of microbial and acanthobibal infections. And so we have also to educate the optometrists in these conditions. Now, coming back to the base of your question, anybody complaining from dry eye symptoms in my office does tear check just before I see him, because I would like to examine the patient and use tear check data to make him understand the correlation between what he's got or she has got and what we are going to do for him. Actually, at the beginning, I was very reluctant in suggesting IPL. I was really, I was not very sure. Now I am positive. It's not for everybody, but 80% of the patients go well, in the sense that we do not really expect to see much difference. We see the difference in tear check when we do the comparison, but the best thing that can happen to you is when the patient comes in and says the symptoms are better, or I am free of symptoms. Thank you.
Very good. Very good, Dr. Tsiganos. You are completely right, because dry eye disease is related to all kind of patients that we have in our daily routine. So dry eye disease is not an isolated disease, an isolated entity. We must think about dry eye disease in relation to all our patients, to our daily patients, like contact lens wear, glaucoma patients, cataract patients, refractive surgery patients, women in menopause, elderly patients, and now young patients, like Dr. Bernard said. So all of our patients in our office are potential patients to have dry eye. So we must be aware of this disease, and I would like to listen from you, and I would like to listen from Dr. Benatti. What's your daily practice for treating dry eye?
Okay, before that, I just want to add something that Dr. Tsiganos said that for me is also very important. Nowadays we are talking about refractive premium surgery or cataract premium surgery, and we can separate premium surgery without ocular surface study, because we know that our results are they don't gonna be good if we have a bad ocular surface. So if we have a practice where we are doing premium cataract or refractive surgery, we have to be aware about this, and we have to study very well the ocular surface and the dry eye possibility before go or move forward to surgery, right?
If you make a research among us, all of us here who performs cataract and refractive surgery, I think all the propedeutica will be the same. We do topography, corneal tomography, we do retina examination, we do OCT, macula OCT, looking for problems in the macula. But who here examines the tear film before the ocular surgery, before cataract surgery? And if you have a dry eye, you have a different keratometry. You have different astigmatism. If you don't treat it prior to surgery, just finish it. If you don't treat your patient prior to ocular surgery, the biometry will give you an error in the calculation of the intraocular lenses. If you're going to implant a trifocal or a toric IOL, you have problems after the surgery.
Sorry, Lina. We are seeing that epithelium atrophy in dry eye disease. So imagine that we are a keratoconus surgeon or a PRK surgeon, and we want to do a trans PRK, and we are going to have problem with that epithelium who is suffering an atrophy by the dry eye. So dry eye is present in every part of the eye, in every procedure that we want to do. So.
Okay. So let's go for the second question. Dr. Strate, what's your personal experience with tearcheck device and grading scale reports, and how it helped you to improve dry eye management?
As I told you, for me it was a surprise. The number that Dr. Nobrega told you about, that we had such a huge number, was because in Romania it was the first IPRL device. And not that only, we made, like, let's say, a Facebook advertising about it, because we were expecting it for a long, long period of time. And my dear colleagues actually were very nice, and they referred to me a lot of patients. But I want to tell you that we realized that half of our cases were very good candidates for IPRL. So we were shocked. We said, in Romania there is so much MGD, and we didn't know it because we didn't have so many devices to check this out. For me, first it was a surprise, and then let me tell you that I went to some national congresses and tell about, you know, guys, we really have a problem here. We do have a huge number of patients suffering from MGD, and you didn't realize it. So now on, it becomes a practice among other ophthalmologists, which I'm proud of, that I started a trend, but it was a good trend. It was about to happen. On the other hand, I would like to tell you that I'm also involved in myopia control. And although the population in Romania is not that myopic as in Asian population, we encountered a number of kids were contact lens wearers and ortho-K wearers that in time, while becoming in the puberty period, they have a change in the tear film, and we could explain to them more than usual why it's important to clean up the lenses, because you see here, see how your tear film is becoming. And about what you said about the abortive blinking, actually for me it was very important to tell the patient, you know what to do from now on? Put a post-it on your laptop that says blink. Whenever you see that post-it, please do a complete blinking. It's going to be helpful. So that was my experience.
Very nice. Not just the post-it to remind them to blink, but we have to teach them how to blink, because otherwise they will blink very fast or very hard. So it's not the adequate way to blink. So teach your patients to blink softly and completely, just touching the upper eyelid and the inferior eyelid. Unfortunately, we have to teach everything to our patients. Every detail is important to manage dry eye. Dr. Lal, how is your personal experience with the tear check and grading scale, and how help you to improve dry eye management?
Well, the tear check itself has already helped us to classify the dry eye disease as mild, moderate, or severe. Those that have a moderate to severe dry eye disease, we will explain to them the importance of having IRPL as what the technology today allows us. And those in the mild zone, in the yellow zone, if they are not, if they are reluctant to pay because you have to pay from their own pocket for this IRPL treatment, if they are in the yellow zone, then I would allow them to use just eye drop treatment for treating their dry eye disease.
Very good. Thank you, Dr. Lowe. And Dr. Siganos, how tear check helps and how grading scale reports help you in management dry?
Okay, just to back up, in Heraklion, people that go around 20 times a day doing blinking exercises, they are my patients. So they are spotted. So I recommend corpse exercise for all my patients and with dry eye, and I also teach them how to look into the computer through a down gaze, you know, and take breaks and put artificial tears in between and so on. So, okay, just for the record and for the history, you know, Crete is the birthplace of LASIK. We were with Palikaris, we were the first to do LASIK, and very early, it was 2002, 2003, we were seeing in topography, in the upper part, stippling. Sometimes we were calling it superior keratoconus. It was MGD, nothing more than MGD. At that time, we didn't have anything more than lid cleaning and artificial tears to give and not go into surgery until it heals. So that's why tear check is extremely helpful, giving us all these parameters that we can show to the patient and can compare. And strangely enough, you said it earlier, for me, even though all are important, the most important is the questionnaire, because it makes the patient understand, you know, what he's got, and makes the patient understand why he's getting better after you do the IPL.
Excellent. That's why I always start by eye fitness test, because it gives you the idea of the symptoms. It's an educational tool also for patients. As you make the questions and the answers, they are getting educated about the impact of dry eye over the quality of vision and the quality of life. So, Dr. Benatti, what's your experience with the tear check and grading scale and how it helped you to manage dry eye?
Well, I talked about it a little bit in the presentation. I think it really changed my practice, because the main thing that I can do is educate my patients. And the adherence to the treatment, you said it very well, it's really important. And I'm convinced that after tear check, I can convince at the same time my patients, because they understand what is happening in their eyes, and they really want to see the improve, right? They come after treatments and they say, okay, how is my eye fitness test now? How are the colors right now, the table of the colors? And I think it's very important. It's easy to use, it's practice, and it's perfect for this moment with all these patients. We really need it.
Great, excellent. The grading scale gives us a very comprehensive overview for the patient, and it's a great educational tool. You can track changes over time. You can repeat anytime you want, so the patients can see their results pre and post treatment. So it's very nice, and with no doubt it increases the compliance for treatment when you show images.
And something so simple like colors help us a lot and helps patients to understand.
Exactly. Suddenly, the patients, as soon as they look at the scale,
they understand immediately. So it makes our job easier. So let's go for the third question. Dr. Strate, what's your best practice and the best valuable benefit from using E-Eye device?
Well, I have said it yesterday, I'm going to say it again. I was also the first patient treated for this kind of MGD in Romania because I tried it on myself. So the results are here in front of you. I'm a 27 years contact lens wearer. So I have a very not severe MGD, but not a common one. And actually it boosted everything in my practice. The confidence that the people are getting from the pictures and the follow-up, it's amazing. And as you said, was there any adverse events? Well, there was one. Our male patient fainted while we put the gel on. We didn't make it to the IRPL. Unfortunately, he wasn't in the study. I completely said, you know what, if that's the kind of fear that you're getting from this intense light pulsation, let's stop here. We will try something else in the future. I'm sure that is going to be invented something for me. So it really changed my life, my personal life, and I'm sure for all my patients.
Excellent. Dr. Lau, what's your best practice from the E-Eye?
The message that I always like to give to my patients, even before starting the E-Eye, is to let them know that dry eye disease, there is no permanent cure. This, like BLIFX followed by IRPL, is something that we can do to help them. But they have to help themselves too. At home treatment, using at least, I always describe 3 things to them. Number 1, make sure that the hygiene of your eyelids are clean with lid wipes, perhaps even every night if possible before you sleep. Number 2, make sure that you put your eye drops. At least you put the eye drops. We don't expect you to put the eye drops hourly to 2 hourly. After the IRPL, perhaps even twice per day may suffice. And the third thing is that I always stress that you need some supplement. Omega-3 supplement is something that you need to have too. So these are things that you can help yourself. Because dry eye management is not short-term, it's long-term. And IRPL may last 1.5 years, 2 years, yes. And then once you become symptomatic again, at that time, we will repeat the tear check. And if again you fall into the red zone category, we have to repeat the IRPL. All these are well explained to the patients because the last thing you want is the patients will come back and accuse us, you promised me that I'll be healed, but I'm not healed. Yes, because if we fail in this part of our explanation to the patients before we start the treatment, we are going to receive this end.
Excellent, Dr. Lau. It's very important to give this advice to our patients. We are dealing with a chronic disease. We must not promise that the patient will be healed. We are applying a technology that will improve considerably the symptoms and improve quality of vision and quality of life. Patients will be able to work again, so increase the productivity of the countries. Young students can study again. Imagine a medical student at the university and study in front of the computers all day long. This young population are suffering from dry eye. So it's very important not to promise the heal, but make your patient understand that they have a chronic disease. They have to take care of the eyes in a daily basis routine, like we eat, like we take bath, wash our teeth, we hydrate, we go for sleep. And we must take care of our eyes in a daily basis routine. That's very important, and it is a part of educating our patients. Dr. Siganos, what's your best practice of the eye?
Okay. Like I said earlier, I mean, around 80% of my cases, they go well. I mean, the patients are happy. Thinking about it now, I think the happiest ones are the postmenopausal women. They get, I think they are the best results. The rest really depends on the habits and depends on the patient education, as Dr. Vanetti said earlier. Because, I mean, if they go on using the contact lenses the way they use it, say the whole day, you know, so many hours, it's very difficult just with the IPL to, you know, to save it. So, of course, I agree totally that you emphasize that it's only symptomatic relief and not curative. But it could be curative if the patient abstains from contact lenses, okay, if the patient, floppy eyelid. Floppy eyelid is not what you think, an obese person, diabetic. Floppy eyelid or lid laxity in that case is for in many, many people. Contact lens wearers, and we are working now in our lab in the university with a lab of sleep apnea. There is a lot of cases of floppy eyelid and patients that have sleep apnea that never knew about it. So this also is combined with dry eye disease. So if you educate the patient, and also prone position in sleeping. Prone position in sleeping induces lid laxity and floppy eyelid and really increases the symptoms. So if you educate the patient, you might achieve symptomatic relief as well as, let's say, cure.
I totally agree with you, as I am an oculoplastic surgeon. So I deal with this kind of patients, and they rub the eyelids when they are sleeping, and the association with the apnea is very high too. And Dr. Binati, what's your best practice from the EI?
Well, I will answer that question next year in the next symposium, because my EI is coming to Argentina, and I'm very happy about that. But let me tell you, I want to come back to the comment that you did. I would like to tell you another point of view. Imagine that you are a CEO of one of these tech industry or a tech company when they have 30,000 employees spending 8 hours in the computers, suffering at least 40% of them CVS. And there is a survey that says that 65% of the CEOs now, they are worried about the health of the employees. So can you imagine the numbers of patients or workers suffering this just in the tech industry? So what I want to say with this, that the number of patients is going to be even bigger and bigger and bigger. And we are worried about it, and again, we need to be prepared for that.
Yes, there was a study made in my country, in Brazil. They studied young population. They found an overall prevalence of 24% of students at the university. So if you think it's a high prevalence of dry eye disease among young students, and they have the whole life ahead. So they are very young and they are feeling discomfort.
Absolutely.
So that's a big problem for us. I want to comment about my experience with the E-Eye. I've been using E-Eye since it reached Brazil in 2019. So I have 4 years of experience with the treatment, and it really changed completely my relationship with dry eye disease and MGD patients. I think I spoke that yesterday on my booth lecture, that IRPL is a technology that has evidence in improving all those mechanisms of MGD, which are inflammation, Demodex, bacterial burden, telangiectasias, stasis of the meibum. So IRPL is a technology that has evidence to improve all those findings in MGD. So it was a breakthrough for eye care practitioners, in my opinion. It has changed my relationship with the disease and with these patients. So I can offer my patient a technology that improved quality of vision, that improved quality of life. They smile again. So I've been treating dry eye since 2007, only with changing habits and topical treatment. And suddenly I have a technology that helped me a lot to improve my patients. So it also changed my life and the way I deal with these patients. So let's move on to the next question, to Dr. Strate. What do you think will be a future of dry eye in the next 5 years?
That it's very interesting. I also work in the research department in University Hospital in Bucharest that has a very nice team. And I think that we have many plans to work on. We have the tear check. This is good, so the imaging it's right, but I think the diagnostic test needs to be improved in order to get, let's say, the earliest possible signs that we are not getting right now. Of course, as I told you, in Romania, we discovered a lot of patients, but that's one point, the diagnostic tool. Then the medication or the personalized treatment. Now we have the IRPL, but I think in the future we are going to talk about other kind of therapies like stem cells, exosomes, and everything. So I think it's going to be interesting. Let's not forget about artificial intelligence that is going to help us to identify patterns and try to get the best results for our patients.
Excellent. We can't wait what's coming next. Dr. Lau, what do you think will be the future of dry eye?
I think as cataract and refractive surgeons, in our practice, as the future comes along, we will have to dedicate more and more time for this dry eye disease, because as we all know, this is all because of lifestyle changes, as well as people are growing older. So we are actually seeing dry eye disease at both ends of the age spectrum. It's not just confined to senior folks like us. Obviously, our children and the young people do have dry eyes. And some studies say that children, in the younger people, it's more due to the aqueous deficiency rather than lipid deficiency. But with the tear meniscus examination, we can assess whether it's really tear, aqueous deficiency, or lipid deficiency dry eye disease, and then we treat as appropriate.
Excellent. Dr. Tsiganos?
Well, dry eye disease in 5 years will be eliminated by ESW. Okay, seriously now. Except for the environmental factors with like climatic changes, which are very important, deteriorating factors and habits and all the things we discussed about, I think neurotransmitters will be very important in the future. To understand fully how things work and how we can be able to produce tears through neurotransmitters in the lacrimal gland. At this point, strangely enough, of course, I treated 2 cases of Sjögren with the IPL. It sounds crazy, right? Because Sjögren with filamentous keratitis, they just have no tears, or very, very few tears. That was the problem. However, low tear production or dryness causes MGD, and MGD causes dryness. Therefore, when MGD was treated, she was, how Sjögren is painful. Okay, she was extremely happy. Of course, with other treatments, okay, you know, plugging contact lens for the filaments and everything. But it worked. I don't know, it partly worked, let's say. Therefore, neurotransmission is, I think, the future for dry eye disease combating.
Excellent. Dr. Benatti?
Well, hard to answer after the wonderful answer of Dr. Siganos, right? But I think that meanwhile we are having this lifestyle, dry eye will be doing a big problem for all of us. So there is no signs of changing in this lifestyle that we are doing now, we are having. Cell phones, computers, laptops, screens, environment, air conditioning, and dry eye will be with us for a long, long time. So let's be prepared. That's the message.
I want to give my opinion, but not so technological opinion. I think I will give opinion about our behavior in related to dry eye. I think maybe in 5 years, every surgeon will be screening for dry eye. So if you change the educational part of our colleagues, optometrists, because we don't have optometrists in Brazil, so but optometrists and ophthalmologists, educating them to give a different and more appropriate importance to this disease. So maybe in 5 years, we will screen every patient prior to any ocular surgery, and maybe can change the way we ourselves behave related to this disease. That's what I hope that we are trying to do with a symposium like that. We're trying to do in our countries with lectures and educate our patients in a daily routine. So it's very important for us not to give up and continue with this fight. So thank you.
One point in that. This is what you're saying is I agree totally. I'm not sure that it will happen. Because really, you know, if you come back, I'll give you an example. The elderly cataract surgeons were routinely doing lacrimal duct irrigation before surgery. We never do that, right? So I'm not sure. I hope it will happen. I hope they will be alert, but I'm not sure about that.
Let's hope. So I think we are on time. I want to thank all the panelists for this wonderful roundtable and discussion. And that's a wrap up. Okay.
I hope that all of you enjoy a nice evening with us. And I want to thank again all our panelists, especially Charlan Busiganos from Greece, Dr. Aloysius from Malaysia, Cinziana Istrate from Romania, Andres Benatti from Argentina, and a really big thanks to Liliana, been excellent moderator of this event. And before we end, just let me, before we jump to the dinner, and to feed also our stomach, not only our emotions, I would like to give a thanks to 2 centers that haven't been with us yesterday. The one that create the biggest impact in this clinical study. I would like to dedicate thanks to one of the larger collector in this clinical study, to center from Malaysia, Vista Clinic, Dr. Aloysius. Thank you so much for participation. We appreciate your big effort. It was a big impact. Thank you. Thank you. And not last of least, I have my personal thanks to the small eye center in the heart of the Europe, in a small city where I was born. I don't want to cry, but anyway, this is the smallest center that I think should be a good example that dry eye clinic can exist, can work very efficiently, and you see that they collect enormous number of the patients in this clinical study, and they've been make a very big improvement, and I think they create a lot of satisfaction and happiness and happy patients. So I would like to thank Carpathia Center in Slovakia, especially Dr. Marhitic. Please come on stage. Nurse Eva Stiskalova. Janko Kriška, the owner of the clinic, that without him would never happen. So I'm very happy. Please, Janko, don't be ashamed. And so thank you so much for participation, for your hard work. I know that how hard it is to come from Ukraine, live in Slovakia, and make this very interesting footprint in the dry eye in Slovakia. As a beginners, as a Cinciana, they are the first starters in Slovakia. Thank you so much. So, this is the end. No, it's just the beginning. So please, please be welcome. Enjoy our small refreshment, nice dinner. Please discuss with our panelists, our excellent doctors, Liliana. I think they still have a lot of to tell. So thank you so much again for coming. And I also thanks Mike Media for having this also happening. Also our team of ESWV Vision, our CEO and President Petra, for making us to come to his event. Thank you so much.
Most of our patients, even in the younger age group, the moment they wake up, they are already on a handphone. So digital gadgets itself, is inducing dry eyes, even at a very early age. And as we grow older, that's where hormonal changes comes in, and that again induces dry eyes. We are going to find that most of our patients will not be happy with us, especially after refractive procedures like, example, LASIK or refractive cataract surgery. If we do not address this issue, the long-term effect will be a reduction in the work productivity, and the quality of life as well as quality of vision in the patients.
Tearcheck has a great impact in our practice because, as you know, we can do a very smart and efficient diagnosis of dry eye, and that is very important for the patients because now they understand what is happening with their eyes. Before that, it was a little bit harder to explain to the patients and to understand to the patients what is happening. But now with tearcheck, we have the tools, we have the technology to understand and to teach to the patients what is happening.
I've been following the products of this company for a long time, and I was not very sure about using the equipment. When I saw how meticulous work was done and the studies, I decided to go into it, and I was surprised, about the results and the patient satisfaction. There was a case of, after refractive surgery, a patient that even though the refractive surgery was successful, she was not happy with her vision. She had blurring, among other symptoms. So she came to me and I diagnosed dry eye and meibomian gland dysfunction. She was treated with IPL, and in 3 months' time she could see 20/20. She had a 20/20 vision. Therefore, that was the reason, and the treatment in that case was very successful.
Before technology, we used to treat our patients with topical treatments, but with the technology, for example, the IRPL, which is the intense regulated pulsed light from ESW Vision, it changed completely. It's a technology that has evidence to improve all those findings in MGD. So for me, it was a breakthrough for eye care. It really has changed my relationship with the disease, so I can offer my patients a fast, efficient, and safe procedure in my office, and I can improve ocular symptoms, and I can improve the quality of vision, and I can improve the quality of life much sooner than I used to do before.
It is very important to have a preoperative management. So we have like premium IOLs and premium surgery. So if you want to do something premium, you should go also to the ocular surface. And for us it was a breakthrough because we encounter many complaints after the surgery of the patients. And now we just perform IRPL before the surgery. We explain the problems, we tell them that these are the limitations of the treatment, but we can do something for them to get implanted with a high quality IOL also, or to have a very good refractive surgery with quite nice outcomes.
ESW Vision are now officially since 2016 in the market in the field of dry eye management. From the beginning on, me as a CEO of the company, but all our team in R&D, we decided to stay focused and dedicated to dry eye. With our product line today, with tearcheck, with E-Eye, we know that we can really support with a complete dry eye management solution. And it's not just a marketing claim to discover the difference with our technologies. The future for us we really see as a very serious challenge, not only from our side in developing products, but as we understand from the eye care experts, dry eye management and dry eye disease in general change dramatically. More and more younger generations will be affected, and so our products should fit into the new future needs.
The dry eye becoming more and more interesting spot to talk about it. Finally, the dry eye is the beginning of the problem in ophthalmology. And now I can see how its impact for the lens implantations, refractive surgeries, and for happiness of the patient. So feedback is great. So I'm so happy that I can represent the product that really works. And the feedback from the doctors, and especially those who are working with our devices, it's so excellent. With the new improvement, we made their work even more easy. We want to make our patients happy and the doctors happy that they finally feel they have not less work, but easier. And this is what we want to achieve, to make their life easier and to use the smart technologies like ours to achieve the happiness of our patients. This is our goal.